Neurology. Condition, headache approach. Headache can be primary or secondary. Headache type. Primary headaches. Migraine. Headache characteristics. Recurrent attacks that last for 4 to 72 hours. Typically one-sided, not side-locked, can be bilateral, pulsating, moderate to severe intensity, aggravated by routine physical activity, associated with nausea and/or photophobia, phonophobia, or osmophobia. Can occur with or without aura. Migraine can present primarily as neck pain or mid-facial pain rather than headache. The associated features listed above are important in making the diagnosis. Migraine with aura. Migraine that is preceded by aura, i.e., reversible focal neurologic symptoms that usually develop over 5 to 20 minutes and last for lt 60 minutes. Aura symptoms can affect vision, senses, speech and/or language, motor function, brainstem and retina. Exclude transient ischemic attack. Aura without. Headache. Acephalgic. Migraine. Typical aura of migraine that is not accompanied, or followed, by a headache of any sort. Common form is scintillating scotoma. Can occur at times in a patient who usually has a headache after aura. It is the predominant form of migraine in a few patients. Differential diagnosis must exclude aura mimics, especially transient ischemic attack. Tension type headache. Lasts from 30 minutes to 7 days. Usually bilateral, feels like pressure or tightness in head. Mild to unilateral autonomic, moderate intensity, rarely severe enough to prevent walking or climbing stairs. Not associated with nausea, may be associated with photophobia or phonophobia. Does not fit diagnostic criteria for other headache types better than criteria for tension type headache. Trigeminal, autonomic, cephalalgias, unilateral and side-locked, usually follow. Distribution of first division of trigeminal nerve, with unilateral autonomic features, example tearing, conjunctival injection/irritation, ptosis, nasal stuffiness/rhinorrhea, fullness of the ear, tinnitus, facial flushing or sweating. Possible photophobia or phonophobia, usually unilateral. Patient often agitated and restless. Reversible cerebral vasoconstriction syndrome. Thunderclap, recurring over 1 to 2 weeks. May be triggered by exertion, Valsalva monover, sexual activity, or strong emotion. Can also be triggered postpartum or by serotonergic and sympathomimetic drugs. Can be associated with fluctuating neurological deficits and seizures. Angiography shows string and bead appearance, but may be normal in first week. Changes on MRI are mainly posterior and may include edema, infarction, subarachnoid hemorrhage or intracranial hemorrhage. Persistent. New daily. Persistent. Headache. Persistent and daily since onset, usually patient remembers starting date, present for more than 3 months. No other characteristic features, may be like a migraine or like a tension type headache. Can resolve spontaneously over several months or become chronic. Primary headache, associated with sexual activity, benign sex, headache. More frequent in males than females. Usually benign, although thunderclap headache at orgasm can, rarely, be associated with subarachnoid or infarction. May occur before, usually milder, or at, usually more abrupt and severe, orgasm. Often resolves spontaneously over a few months. Consider reversible cerebral vasoconstriction syndrome. Exclude space-occupying lesion or aneurysm. Primary exercise, headache, benign. Exertional, headache, only occurs after strenuous physical activity, especially in hot weather or at high altitude. Lasts, and lt 48 hours. Exclude space-occupying lesion. Aneurysm, carotid stenosis, posterior fossa mass lesion or Chiari malformation. May be an unusual presentation of angina. Primary stabbing, Headache, also known as ice pick, headache or jabs and jolts, transient and localized stabs of pain in the head, occur spontaneously in the absence of or disease in underlying structures or cranial nerves. Each stab lasts a few seconds. Stabs recur irregularly, mainly extratrigeminal, but can change site. No associated autonomic features. Can occur with a migraine and often ease when migraine is treated. Isolated cases are so brief and infrequent that treatment is not warranted. Persistent cases may respond to indomethacin. Primary cough headache, benign cough headache. Provoked by cough or Valsalva maneuver, can last seconds to 2 hours. Exclude space-occupying lesion or aneurysm, posterior fossa pathology, Chiari malformation and cerebrospinal fluid obstruction. Hypnic headache. Typical patient is older, and GT 50 years, and woken early, 1 to 3 a.m., by bilateral headache, often with nausea. Headache usually lasts 30 to 60 minutes, up to 4 hours. Can often be prevented by 1 to 2 cups of coffee before bed. Lithium, melatonin, and indomethacin may also be used. Secondary headache. Low cerebrospinal fluid pressure headache. Generally worse in evening and improved by lying flat. May be associated with coat hanger pain across the shoulders or pulsatile tinnitus. Intracranial pressure and LT6-CMH2O. May be spontaneous or follow trauma or dural puncture. Increased cerebrospinal fluid pressure headache, associated with raised intracranial pressure, and GT25-CMH2, measured by lumbar puncture manometry in the lateral decubitus position. Typically worse in the morning and when lying down, improved by upright posture. Aggravated by cough, straining and Valsalva maneuver. May be associated with transient visual obscuration, pulsatile tinnitus, and papilloedema. Exclude a space-occupying lesion, venous sinus thrombosis or obstruction, and use of drugs such as tetracyclines and vitamin A analogs, example isotretinoin, acitretin. Consider idiopathic intracranial hypertension, especially if recent weight gain. Visual field loss and permanent damage can follow initial transient visual problems. Papilloedema. Exclude a space-occupying lesion, venous sinus thrombosis or obstruction, and use of drugs such as tetracyclines and vitamin A analogs, example isotretinoin, acitretin. Consider idiopathic intracranial hypertension, especially if recent weight gain. Visual field loss and permanent damage can follow initial transient visual problems. Headache. Cervicogenic headache. Usually accompanied by neck pain and is unilateral, side locked, with radiations from posterior to anterior. Due to disorder of cervical spine, example bone, disc, soft tissue. Neck has reduced range of movement. Headache is provoked by neck maneuvers or digital pressure on affected structures. High cervical or greater occipital nerve block may relieve symptoms. Headache induced. Drug induced headache follows intake of drugs, example alcohol, marijuana. Cocaine, monosodium glutamate, nitrates, cyclosporin, phosphodiesterase inhibitors, carbon monoxide, exogenous hormones. Headache induced by metabolic/other medical condition. Patient has a medical condition associated with the headache, example obstructive sleep apnea, hypoxia, pheochromocytoma, hypoxia, arterial hypertension. Pheochromocytoma, epilepsy, hypoglycemia, hypercapnia, hemodialysis. Red flags that raise the suspicion of a secondary cause include first or worst headache, abrupt onset or thunderclap attack, progression or fundamental change in headache pattern, Abnormal physical examination findings. Neurologic symptoms and GT 1 hour. New headache in persons and LT 5 years or and GT 50 years. New headache in patients with cancer, immunosuppression, or pregnancy. Headache associated with alteration in or loss of consciousness. Cognitive, sensoromotor, reflex, and cranial nerve assessment as well as evaluation of the cranium, cervical spine, carotid and temporal arteries. Temporomandibular joint, and the ears and sinuses, are essential to a comprehensive evaluation. When there are red flags, imaging becomes essential. Neuroimaging is the most sensitive diagnostic tool. The decision as to which type of imaging is most appropriate depends mainly on the urgency of the imaging and the main differential. CT scan is preferred for skull fracture, acute SAH or itch, and paranasal diseases. MRI is preferred for most other causes of acute or chronic headache. CT/MR angiographic studies are preferred when vascular pathology is suspected. CSF examination may be performed if SAH is suspected, xanthochromia, but CT scan is normal, and when meningoencephalitis, meningeal carcinomatosis, and disorders of intracranial hypertension or hypotension are suspected. ESR and CRP are requested if giant cell arteritis, GCA, is suspected, followed by temporal artery biopsy for confirmation. Thunderclap headache. Severe headache that reaches maximum intensity within 60 seconds of onset. Common causes: SAH, ischemic and hemorrhagic stroke, acute venous thrombosis, sentinel bleeding from an unruptured cerebral aneurysm, intraparenchymal hematoma, dissection of a carotid or vertebral artery, thrombosis, pituitary apoplexy, spontaneous intracranial hypotension, reversible cerebral vasoconstriction syndromes, posterior reversible encephalopathy syndrome, colloid cyst occlusion of the third ventricle, and primary headache disorders, stabbing, cough, exertional, sexual activity. Thunderclap. Always approached as a neurologic emergency, thus, plain cranial CT scan should be immediately requested. Reversible cerebral vasoconstriction syndrome, recurrent thunderclap headache with possible focal neurologic signs, normal or near normal CSF, and angiographic documentation of multifocal segmental cerebral vasoconstriction that completely resolves within 12 weeks. May be idiopathic, or associated with preeclampsia or eclampsia, medications, sympathomimetics, blood products, or catecholamine secreting tumors. Treat with CCB, nimodipine or verapamil, steroids, or magnesium. For primary thunderclap headaches, treat with NSAIDs, especially indomethacin, and BB for those with exertion triggers. Idiopathic intracranial hypertension. CSF pressure elevation in the absence of obstruction or an intracranial space occurring lesion. Not always benign. Most commonly affected are females, overweight, and of childbearing age. Headache, visual symptoms, and tints are the most common presentations. Diagnosis is confirmed by elevated CSF pressure, and GT 250 mmH2O. Treat the cause if there's any. Treatment options include weight loss, lumbar puncture, palliative, serial punctures in pregnancy, acetazolamide, or surgical shunting/decompression. Trigeminal neuralgia, tic-douloureux. Recurrent episodes of brief electrical shooting pain, oftentimes after a trigger, talking, chewing, touching, eating, limited to the distribution of the trigeminal nerve, typically second and third divisions. This is in contrast to herpes zoster, which typically affects the first division. Likely cause in older adults is vascular compression of the trigeminal root entry zone at the level of the pons, which leads to focal demyelination and aberrant neural discharge. In younger patients, consider multiple sclerosis as a cause. MRI of the brain with contrast should always be requested, although only a few would have causative intracranial lesions. First-line medications: carbamazepine, oxcarbazepine, alternative. Second-line medications: baclofen, gabapentin, clonazepam, lamotrigine. Other options if medical management fails include rhizotomy, radiofrequency thermal lesioning, glycerol injection, gamma knife radiation, and microvascular decompression. Migraine usually begins in late childhood or early adolescence, more common in pre-adolescent boys, but becomes more common in adult women. Typical migraine consists of a unilateral, throbbing headache accompanied by photophobia, phonophobia, and nausea. Extensive variability exists. Aura exists in 30% of patients, with visual experience as the most common, flashing of lights, enlarged blind spot rimmed with a shimmering edge or jagged lines in the peripheral vision, but may also include numbness or tingling sensation, disturbed thinking or speech, and dizziness. Aura is typical if it involves any combination of visual, hemisensory, or language abnormalities, with each symptom developing over a minimum of 5 minutes and lasting a maximum of 60 minutes. Auras should be investigated if it goes beyond 60 minutes, involve any focal motor weakness, hemiplegic migraine, or display brainstem symptoms, such as diplopia, dysphagia, ataxia, vertigo, dysarthria, or synchronous bilateral sensory dysfunction, basilar migraine. If attacks occur fewer than 15 days per month, it's called episodic. If attacks occur at least 15 days per month for more than 3 months, with the individual episodes meeting the criteria for migraine on at least 8 of those days, it's called chronic, transformed. Risk factors for transformation from episodic to chronic include older age, major life changes or significant stressors, female sex, low education/socioeconomic status, head/neck trauma, obesity, presence of comorbid pain and sleep or psychiatric disorders, high caffeine or nicotine intake, overtreatment with acute headache medications, medication overuse headache. Women with any migraine type who use combined oral contraceptives have a 2-fold to 4-fold increased risk of stroke compared with women without a history of migraines. Acute migraine treatment. Non-pharmacologic treatment include cold packs over the forehead or back of the skull, targeting the supraorbital and greater occipital nerves, hot packs over the neck and shoulders, targeting the innervation of the scalp, neck stretches and self-mobilization. Rest in a quiet dark room. Acute pharmacologic treatment, non-opioids. Aspirin soluble, line, 900 to 1000 mg orally, may be repeated after 4 to 6 hours to a maximum dose of 4g in 24 hours, or ibuprofen, 1 st. line, 400 to 600 mg orally, may be repeated after 4 to 6 hours to a maximum of 2.4g in 24 hours, or diclofenac potassium, 2 nd. line, 50 mg orally, may be repeated after 4 to 6 hours to a maximum dose of 200 mg in 24 hours, or naproxen, 2 nd. line, 500 to 750 mg orally, may be repeated after 4 to 6 hours to a maximum dose of 1250 mg in 24 hours, or paracetamol soluble, 2 nd. line, 1g orally, may be repeated after 4 to 6 hours to a maximum of 4g in 24 hours. Acute pharmacologic treatment, antiemetic, add-on to non-opioids. Metoclopramide, 1 st. line, 10 mg orally, up to 30 mg in 24 hours, or domperidone, 2 nd. line, 10 to 20 mg orally, up 30 mg in 24 hours, or ondansetron, 2 nd. line, 4 to 8 mg orally, up to 16 mg in 24 hours, or prochlorperazine, 2 nd. line, 5 to 10 mg orally, up to 30 mg in 24 hours. Acute pharmacologic treatment, triptans plus non-opioids. For non-responders to a non-opioid analgesic plus antiemetic, elatriptan, 1. St. Line, 40 to 80 mg orally, may be repeated after 3 hours to a maximum of 160 mg in 24 hours, or, naratriptan, 1. Line, 2.5 mg orally, may be repeated after 4 hours to a maximum dose of 5 mg in 24 hours, or, rizatriptan, line, 10 mg orally, may be repeated after 2 hours to a maximum dose of 30 mg in 24 hours, or, sumatriptan, 1. Line, 20 mg intranasally, may be repeated after 2 hours to a maximum dose of 40 mg in 24 hours, or, sumatriptan, 1. Line, 50 to 100 mg orally, may be repeated after 2 hours to a maximum dose of 300 mg in 24 hours, or, zolmitriptan, 1. Line, 2.5 mg orally, may be repeated after 2 hours to a maximum dose of 10 mg in 24 hours, or, sumatriptan, 2. Line, 6 mg subcutaneously, may be repeated after an hour to a maximum dose of 12 mg in 24 hours. Treatment of intractable migraine, status migrainous. For non-responders to first-line oral treatment and is severe, sumatriptan, 1. Line, 6 mg subcutaneously, only if a triptan has not been given in the last 24 hours and a parenteral triptan has not been tried, or, ketorolac, 2. Line, 30 mg by slow deep injection intramuscularly, only if an oral NSAID has not been given in the last 4 to 6 hours. If parenteral triptan or NSAID is contraindicated or non-responder, and in hospital, give chlorpromazine 12.5 mg in 100 ml of normal saline intravenously over 30 minutes, may be repeated twice, 30 minutes after preceding infusion ends to a maximum of 37.5 mg. If dystonic reactions occur, treat with benzatropine 1 to 2 mg intravenously as a single dose. An alternative to chlorpromazine is dexamethasone 12 to 20 mg intravenously, may be repeated after 12 hours if needed. Dihydroergotamine, not given 24 hours before or after triptan use, and lidocaine, last option and given as inpatient, are additional therapeutic options for intractable migraine. Migraine prophylaxis. Eliminate triggers and risk factors, healthy lifestyle, behavioral therapies. Pharmacologic prophylaxis is recommended in 6 situations. Headache frequency greater than 2 days per week, or 8 days per month. Use of acute medications more than 2 days per week. Headache attacks that remain disabling despite aggressive acute intervention. Presence of prolonged aura, and GT1 hour, complex aura, basilar or hemiplegic, or migraine-induced stroke. Contraindications to, failure or overuse of, or adverse events with acute therapies. Patient preference. Agents typically used for prophylaxis include amitriptyline, candesartan, nortriptyline, pizotifen, propranolol, sodium valproate, topiramate, and verapamil. Usual short-term prophylaxis for menstrual migraine include ibuprofen, naproxen, and naratriptan. Choice of prophylactic medication should depend primarily on efficacy, with consideration given to coexisting psychiatric or medical disease, patient preference, and patient adherence. Comorbidity. Drugs to consider for migraine prophylaxis. Drugs to avoid for migraine prophylaxis. Insomnia. TCA, pregabalin, gabapentin. Anxiety, postural orthostatic tachycardia syndrome. Propranolol. Obesity, diabetes. Candesartan, topiramate. Drugs to avoid: sodium valproate, pizotifen. Fibromyalgia. Drugs to consider for: TCA, pregabalin. Neck muscular tension, bruxism. Drugs to consider: TCA. Asthma. Drugs to avoid for: beta blockers. History of renal calculi. Drugs to avoid: topiramate. Current or past history of depression. Agents typically used for drugs to consider for migraine SNRI, SSRI, drugs to avoid for migraine be cautious using topiramate, beta blockers, flunarizine. Untreated or inadequately treated menopause symptoms, hot flushes. Drugs to consider for propranolol, gabapentin, SSRI. Evidence for episodic migraine prevention is strongest for propranolol, timolol, amitriptyline, divalproex, and topiramate. Evidence for chronic migraine only supports oral topiramate, risk of kidney stones, and injectable onabotulinum toxin A. Allow a trial of 4 to 8 weeks for each drug, and provide maintenance treatment of 6 to 12 months after a response. Tension type headache. Most common but least distinct. Divided into episodic and chronic subtypes, with the episodic subtypes including attacks that occur fewer than 15 days per month or 180 days per year, and the chronic subtype including more frequent attacks. A diagnosis of exclusion, based on negative characteristics. Usually bilateral, steady, mild-moderate discomfort. Stress and sleep deprivation are the most common triggers. ASA and paracetamol, especially with caffeine, have been shown to be equally effective and superior to placebo, while ibuprofen and naproxen being more superior to these former two. Preventive strategies is mainly by stress management, relaxation, and biofeedback. Cluster headache. Male sex and tobacco use are risk factors, and alcohol may trigger attacks during a cluster cycle. Generally starts a few hours of falling asleep, lasts several weeks or months, with attacks of pain potentially recurring 1 to 8 times daily and lasting 15 to 180 minutes each, typically periorbital or temporal, intense, boring, and associated with restlessness and ipsilateral autonomic features such as ptosis, lacrimation, conjunctival injection, and nasal congestion and rhinorrhea. Do MRI to rule out structural abnormalities. Medical treatment includes acute treatment, and transitional and maintenance prophylaxis. Acute treatment is inhaled oxygen by face mask at 6 to 12 L/min for 10 minutes, and GT 75% efficacy, subcutaneous sumatriptan and nasal zolmitriptan. Transitional prophylaxis, which refers to the short-term use of fast-acting agents, typically involves either corticosteroids or an occipital nerve block. Mainstay of prophylactic therapy is verapamil, monitor with ECG. Some evidence with use of melatonin and lithium, none for. Condition, seizures and epilepsy. Background. Results from abnormal, excessive, or synchronous neuronal activity in the cerebral cortex. Seizure precipitants include fever, infection, intoxication, drug withdrawal or initiation, metabolic derangements, sleep deprivation, or an acute neurologic insult. Epilepsy is diagnosed only after 2 or more unprovoked seizures. Approach. Initially focus on stabilization, checking the airway and vital signs, and identifying and correcting reversible causes. Characteristics of seizures and common mimics in adults. Characteristic. Warning/aura. Seizure. Variable, and LT 1 minute. Non-epileptic seizure. Variable. Syncope. Lightheaded feeling, sweating. TIA. None. Migraine. Variable, 15-30 minutes, vertigo, none. Characteristic. Duration. Seizure. 1 to 2 minutes. Non-epileptic seizure. 5 to 15 minutes. Syncope. Seconds to minutes. TIA. Minutes to hours. Migraine. Hours. Vertigo. Minutes to days. Effect of posture. Seizure. None. Non-epileptic seizure. Variable. Syncope. Variable. TIA. None. Migraine. None. Vertigo. Variable. During. Symptoms. During. Episode. Seizure. Tonic-clonic. Movement. Paresthesias, aphasia. Non-epileptic seizure. Pelvic. Thrusting. Jerking that waxes and wanes, forced eye closure. Loss of tone. Syncope. Loss of tone, brief clonic, jerks. Characteristic. Hemiparesis. Hemisensory, loss, visual loss, aphasia. Migraine, visual, disturbance, vertigo, paresthesias, vertigo, nausea, ataxia. Characteristic, altered consciousness, seizure, common, non-epileptic seizure, common, syncope, sometimes, tia, rare, migraine, rare, vertigo, none. Incontinence, seizure, variable, non-epileptic seizure, variable, syncope, variable, tia, none, migraine, none. Vertigo, none. Heart rate, seizure, increased, non-epileptic seizure, variable, syncope, irregular/decreased, tia, variable, migraine, no effect, vertigo, variable. Symptoms after episode, seizure, confusion, non-epileptic seizure, variable, syncope, alert, tia, alert, migraine, fatigue, vertigo, alert. EEG during event, seizure, epileptiform pattern, non-epileptic seizure, no effect, syncope, diffuse slowing, tia, focal slowing, migraine, rare slowing, vertigo, no effects. Distinction between seizures and other events relies heavily on clinical presentations and should raise suspicion based on the following information. Childhood febrile convulsions. History of trauma with loss of consciousness. History of central nervous system infection. Central nervous system lesion, brain tumor, vascular malformation, stroke. Prenatal or birth injury. If a first seizure resulted from a toxic or metabolic cause, further diagnostic evaluation may not be necessary. Neuroimaging is recommended in any patient with a first seizure, MRI and lumbar puncture in all immunocompromised, and is essential in all patients with an abnormal neurologic examination or a history suggestive of a partial seizure. Lumbar puncture should be considered in a patient with a seizure in the setting of fever, headache, stiff neck, or altered mental status. EEG is not typically done unless there is a prolonged postictal state. All patients who had a seizure should be advised to avoid activities or situations that would pose significant danger. For driving restrictions, refer to Osteroads. Presentation. Either partial, focal, onset in a limited region of the cerebral cortex, or generalized, diffuse involvement of the cortex. Presentation depends on the anatomic localization of the involved cortical neurons that are excited and hypersynchronized during the seizure. An aura, if present, is a clue to the cortical origin of the seizure discharge. Most acute symptomatic seizures are generalized, whereas most epilepsy syndromes presenting in adulthood involve partial seizures. Partial seizures. Simple, intact consciousness, complex, altered consciousness about 1 to 2 minutes, or secondarily generalized, partial seizure that spreads to involve both hemispheres diffusely resulting in a generalized convulsion. Jacksonian march is a simple partial motor seizure characterized by rhythmic contraction of a group of muscles, typically the fingers, followed by a spread of motor activity to the arm and then to the ipsilateral face. The most common epileptic auras, purely subjective symptoms, originate in the temporal lobe, difficult to describe by the patient but may involve vague, rising, epigastric sensations, experiential phenomenon such as déjà vu or intense fear, or autonomic disturbances such as palpitations or temperature changes. In complex partial seizures, in which confusion may remain for as long as 10 minutes, patients may exhibit automatisms, such as lip smacking, repetitive swallowing, or fumbling movements of the hands. Secondarily generalized tonic-clonic seizures are convulsions that begin as partial seizures, characterized by impaired awareness, diffuse muscle contraction, tonic, and rhythmic jerking of all limbs, clonic, often accompanied by urinary incontinence or tongue biting. Often resolve within 1 to 2 minutes. May be followed by postictal confusion or agitation for 10 to 15 minutes. Generalized seizures involve both the hemispheres at the onset of the seizure. Primary generalized tonic-clonic seizures are convulsions that occur with little or no warning. Absence seizures are characterized by a momentary lapse of consciousness, and LT5-SECS. Myoclonic seizures are brief shock-like muscular contractions that can occur in rapid succession and usually are not associated with an impairment of consciousness. Juvenile myoclonic epilepsy, toxic metabolic states, after anoxic brain injury. Epilepsy syndromes. Defined by the constellation of seizure types in a given patient and by his/her EEG and MRI finding. Partial, focal, epilepsy. Temporal lobe is the most common. Complex partial seizure with epigastric and psychic auras, may have evidence of hippocampus atrophy on brain MRI/mesial temporal sclerosis. Other causes include brain tumors, strokes, vascular malformations, and abnormalities of cortical development. Idiopathic generalized epilepsy. Most often occur before the age of 20, but may be late onset, precipitated by alcohol or sleep deprivation. May manifest as generalized tonic-clonic seizure, absence seizure, or a combination. EEG demonstrates bursts of generalized spike wave activity. Neuroimaging is often normal. Juvenile myoclonic epilepsy is the most common. Morning myoclonus/jitteriness, generalized tonic-clonic seizure, or absence. Comorbidities and complications. Mood disorders. Cognitive problems. Osteoporosis. Sudden unexplained death. Diagnostic evaluation. Imaging. Do plain cranial CT in the acute setting, rule out hemorrhage. Cranial MRI for unprovoked seizures, better at detecting structural lesions. EEG. Done both awake and sleep deprived. Can help confirm the presence of epilepsy but cannot exclude its diagnosis. Clinical evaluation and video electroencephalographic monitoring. Done in those patients in whom discriminating between seizures and other paroxysmal disorders on the basis of history alone is impossible. Help discriminate epileptic from non-epileptic seizures. Anti-epileptic drug therapy. The decision to start an AED after a single unprovoked seizure is based on the risk of seizure recurrence. In a patient with a single unprovoked seizure and a normal EEG and MRI, AED is not typically initiated in older patients, and GT 65 years, those with a history of significant head trauma or focal seizure, postictal TOD paralysis, and focal findings on EEG or brain MRI, initiating AED is often justified. Potential adverse effects include sedation, ataxia, rash, phenytoin, lamotrigine, carbamazepine, SJS, and 10. Test for HLA-B*1502 allele among Asians when starting phenytoin, carbamazepine, oxcarbazepine, or lamotrigine. Levetiracetam is an alternative. Efficacy is almost the same for both older and newer AEDs, but the later have better adverse effect profiles, often the basis in drug selection. Whereas nearly all AEDs can be used to treat partial, focal, epilepsies, some agents, such as carbamazepine, gabapentin, phenytoin, and pregabalin, can exacerbate generalized epilepsy syndromes. For patients with generalized epilepsy or if uncertain, use broad-spectrum AEDs such as valproic acid, first-line, lamotrigine, levetiracetam, topiramate, and zonisamide. If focal, carbamazepine is first-line. Carbamazepine and other enzyme-inducing AEDs, such as felbamate, oxcarbazepine, phenobarbital, and phenytoin, can have interactions with other hepatically metabolized drugs and also are associated with an increased risk for osteoporosis and hypercholesterolemia. Lamotrigine is commonly prescribed in women of childbearing age and is also a good option for older patients or those who have depression or other mood disorders. Topiramate and zonisamide can be used for both generalized and partial epilepsy and are associated with weight loss. However, both drugs have been associated with an increased risk of kidney stones and should be avoided in patients with a history of nephrolithiasis. The target dose for an AED is the dose that controls a patient's seizures. Without significant adverse effects, patient determines his/her therapeutic Drug level with phenytoin as a notable exception due to an increased risk of cardiac arrhythmias. Monitor sodium level at baseline and after 3 months for carbamazepine and oxcarbazepine. All patients taking AEDs should be regularly screened for suicidal thoughts. Many patients who have been seizure-free for 2 years can choose to be weaned from AEDs. CME is the exception. AEDs in women. No AED is considered a drug of choice. Valproic acid should be avoided in women of childbearing age. Teratogenesis, exacerbations of PCOS. Carbamazepine, lamotrigine, oxcarbazepine, and levetiracetam have been associated with relatively lower rates of major congenital malformation. Topiramate increases risk of cleft palate. All women with epilepsy should take folic acid, 5 mg/d. AED levels must be monitored closely during pregnancy. Lamotrigine and oxcarbazepine levels drop due to increased hepatic metabolisms, ergo, increased seizure risk. Breastfeeding is generally safe with most AEDs, benefit outweigh the theoretical risk. Estrogen-containing contraceptive agents can reduce lamotrigine levels in women with epilepsy and lead to more seizures if the lamotrigine dosage is not increased. Considerations in the elderly. Likely to have an organic brain disease, thus, higher recurrence rate, dose adjustments. Recurrence rate, lamotrigine, levetiracetam, gabapentin. Dose adjustments. Levetiracetam is the best option for both hepatic and renal failure. Dose adjustment in CKD. Status epilepticus, convulsive. Medical emergency. Defined as persistent tonic-clonic activity with impaired mental status that lasts longer than 5 minutes. Do CABD survey, check glucose levels, administer thiamine with glucose. 4-lorazepam, imidazolam, and 4-diazepam are equivalents and are first-line agents, followed by phenytoin, first choice, or valproic acid. If a patient continues to convulse after receiving treatment, is medically unstable, or has an unprotected airway, intubation and intravenous anesthesia are typically required, often propofol but with risk of rhabdomyolysis and MOF. Patients with CSE who have stopped having clinical seizures are at high risk for NCSE, monitor with EEG if patient doesn't return to baseline after 15 minutes. Status epilepticus, non-convulsive. Defined as persistent clinical or electrographic seizure activity without convulsive motor manifestations. Although management of the electrographic pattern in patients with non-convulsive status epilepticus is controversial, it usually is directed at controlling seizures. Condition, stroke. Background. Characterized by the sudden onset of focal neurologic impairment that can be ascribed to a specific location in the brain, retina, or spinal cord. Either ischemic, lacunar, large artery atherosclerotic, cardioembolic, or cryptogenic, or hemorrhagic, SAH or IH. Diagnosis. Complete neurologic examination. NIS is often used in the acute setting to rapidly measure neurologic impairment. Plain cranial CT is the initial test of choice, to rule out hemorrhage. Infracts are oftentimes not visible in the first 24 hours. If CT is normal in a patient highly suspicious for SAH, LP should be performed. Cranial MRI often gives better definition for ischemic strokes, especially for thalamic and brainstem lesions. Ischemic stroke subtypes. Transient ischemic attack, TIA. Defined by transient focal neurologic symptoms resulting from brain, retinal, or spinal cord ischemia and was initially defined as lasting less than 24 hours, normal neuroimaging. TIA symptoms typically are short-lasting, usually 5 minutes to 1 hour, and include sudden onset hemiparesis, hemisensory loss, change in speech function, either aphasia or dysarthria, loss of vision, or inability to walk, plain CT or MRI within 24 hours. ABCD, age, blood pressure, clinical presentation, duration of symptoms, is the most commonly used scale for risk stratification. 48 hours 0 to 1 equals 0%, 2 to 3 equals 1.3%, 4 to 5 equals 4.1%, 6 to 7 equals 8.1%. Patient characteristics. Score, H and GT / equals 60 Y, 1. BP and GT / equals 140 / 90 mmHg, 1. Clinical symptoms, focal weakness with the TIA, 2. Speech impairment without weakness, 1. Duration of TIA, and GT / equals 60 minutes, 2. 10 to 59 minutes, 1. Diabetes mellitus, 1. Ischemic stroke, cardioembolic stroke AF is the most common cause. Other causes include reduced left ventricular F, severe calcific mitral stenosis, ventricular thrombus or apical aneurysm, or congenital abnormalities such as PFO. Findings on neuroimaging suggestive of a cardioembolic cause include involvement of the cortical surface in the absence of cerebral artery atherosclerosis, presence of more than one infarct, especially if bilateral or involving the territory of both the internal carotid and vertebrobasilar arteries, and involvement of the entire territory of a large intracranial artery. Do cardiac evaluation, ECG, in-hospital telemetry, transthoracic/transesophageal echocardiography. Large artery atherosclerosis commonly occurs after local thrombus formation in the area of plaque rupture with subsequent distal embolization. Extracranial internal carotid artery atherosclerosis has the highest risk of recurrent stroke in the first 2 weeks, suggested by recent monocular visual loss and the presence of a carotid brood. Investigate for common carotid artery, vertebrobasilar, intracranial internal carotid, and middle cerebral arteries, CT, MRA, transcranial Doppler ultrasonography. Small subcortical infarcts, LeCoins. Commonly less than 1.5 centimeters and arise from occlusion of small perforating arteries emanating from the large intracranial vessels. Usually motor and sensory deficits only. Hypertension is the strongest risk factor. Hemorrhagic stroke subtypes. Subarachnoid hemorrhage. Presence as sudden onset of severe headache, thunderclap. Changes in the level of consciousness is the most common manifestation, increased ICP, but may also include early localizing findings such as subhyaloid hemorrhages on fundoscopy and oculomotor nerve palsies with pupillary dilation from direct compression to loss of brainstem reflexes, posturing and deterioration in consciousness. The most common cause is a ruptured cerebral saccular aneurysm. Perform CT angiography, unexplained coma, and catheter angiography, diagnostic and therapeutic. Intracerebral hemorrhage. Suspect in any patient with focal neurologic symptoms and associated headache, nausea, and impairment in consciousness. Perform immediate non-contrast CT. Itch origination from the deep structures of the brain such as the basal ganglia, pons, and cerebellum, is typically due to hypertension, may still be candidates for anticoagulation in the future. Lobar hemorrhages in older patients without hypertension that originate near the cortical surface can be caused by amyloid angiopathy. Anticoagulation and statins should be avoided. Treatment. Ischemic stroke, thrombolysis, aims to restore cerebral blood flow to the ischemic penumbra. Establish eligibility, focuses history and PE, RBG, non-contrast CT, FBC, coagulation profile, basic metabolic profile. BP should be less than 185/110, use labetalol or nicardipine, before initiation and less than 180/105 after thrombolysis. Indicated within 3 hours of onset and who do not meet the exclusion criteria. Optimal time from hospital arrival to treatment with thrombolysis is 60 minutes. Main complication from intravenous thrombolysis is symptomatic itch, defined as intracranial bleeding with an associated decline in neurologic function detected on neurologic examination that cannot be ascribed to other causes. Aspirin and/or clopidogrel, 21-day course of DUAT then clopidogrel monotherapy to complete 90 days. Acute 4-heparin is used only in cases/situations such as dissection, hypercoagulable state, or mechanical heart valves. No recommendation for statins to date. BP lowering in patients who do not receive fourth thrombolysis is only recommended if the BP is greater than 220/120 mmHg or if high risk or evidence of other end organ damage exists. In patients with stroke and atrial fibrillation, anticoagulation can be started before hospital discharge if the risk of hemorrhage into the bed of the infarct is low, such as in patients with infarcts but no petechial hemorrhage, as determined by neuroimaging, or with involvement of less than 1/3 of the middle cerebral artery distribution. In all other non-cardioembolic stroke, warfarin and antiplatelet agents, aspirin or clopidogrel, are of the same efficacy. Review indications for mechanical thrombectomy. Hemorrhagic stroke, intracerebral hemorrhage. Discontinue antiplatelet and antithrombotic agents as well as SSRIs. Options for reducing ICP is by external shunting or osmotherapy. Consider surgical evacuation of hematoma for varibellar hemorrhage greater than 3 cm, especially if with evidence of neurologic worsening or brainstem compression. Other cases are managed on a case-by-case basis. In patients with a vitamin K antagonist-associated itch, fresh frozen plasma or prothrombin complex concentrates are recommended, as is administration of intravenous vitamin K. Administer 4 antihypertensives, nicardipine, labetalol, to target BP of 160/90 mmHg or MAP 110, SBP and LT 140 mmHg within 6 hours results to better reductions in disability. Subarachnoid hemorrhage. In the early phase, patients often have impairments in consciousness due to hydrocephalus and require external cerebrospinal fluid shunting to alleviate and subsequently monitor intracranial pressure. Early coiling or clipping. Monitor early coiling or clipping. Target BP should be less than 140/80 mmHg. Monitor for cerebral vasospasm, ultrasonography, CT angiography. Manage vasospasm with oral nimodipine for 21 days or until discharge and with vasopressors to prevent progression of ischemia, provided that the aneurysm has already been treated. Associated complications include AMI, respiratory failure, cerebral salt wasting syndrome, SIAD, cardiac arrhythmias, and infections. Prevention. Primary stroke prevention. Aggressive risk factor control and not stunting or elective endarterectomy, which should be considered in patients with greater than 80% stenosis and low CV risk. BP control and smoking cessation is strongly recommended in patients with unruptured cerebral artery aneurysm. Secondary prevention. Comprehensive lifestyle change. Lower BP to less than 130/80 mmHg. Target LDL2 and LT2.0 mol/L with statins, maybe CI in patients with lobar itch due to amyloid angiopathy, but are indicated in all patients at high risk for ischemic events regardless of itch subtype. Discontinue anticoagulants for at least 4 weeks in patients without mechanical heart valves who have itch related to anticoagulant ant use. In patients with non-disabling strokes or transient ischemic attacks who have symptomatic extracranial internal carotid artery stenosis, carotid revascularization, preferably within 14 days from the index event, is indicated for secondary stroke prevention. Condition, movement disorders. Background, hypokinetic or hyperkinetic. Movement type. Hypokinetic. Parkinsonism. Clinical features. Cardinal features, bradykinesia/akinesia, rigidity, resting tremor, postural instability. Additional features, freezing gait, stooped posture, masked face, hypophonia. Causes. Parkinson disease, Parkinson plus syndromes, Lewy body dementia, vascular, hydrocephalus, medications, Wilson disease, juvenile Huntington disease. Movement type. Hyperkinetic. Tremor. Clinical features. Rhythmic oscillations of a body part, can occur at rest or with action, postural or kinetic, intention tremor amplitude increased near target. Causes. At rest, Parkinsonism, see above, postural and kinetic, enhanced physiologic tremor, essential tremor, intention tremor, cerebellar. Dystonia. Clinical features. Sustained, stereotyped, and directional twisting and posturing movements of various body parts, can be focal, segmental, or generalized, transient improvement possible with a sensory trick, jest antagonist. Idiopathic or primary dystonia generalized, positive for DYT1 segmental, Mage syndrome, facial and oromandibular dystonia, focal, torticollis, blepharospasm, writer's cramp. Dopa-responsive, damage to the basal ganglia, anoxic injury, postencephalitic, dystonic cerebral palsy responsive, damage to the basal ganglia, anoxic injury, postencephalitic, dystonic cerebral palsy. Medication-induced, acute dystonic reaction, tardive dystonia. Chorea. Random, non-repetitive, quick, unsustained, purposeless movements with a flowing dance-like pattern. Huntington disease, post-infectious, sydenham chorea, chorea gravidarum, autoimmune, systemic lupus erythematosus, antiphospholipid syndrome, hyperglycemia, vascular, drug-induced, neuroacanthocytosis. Hemibolismus, unilateral high-amplitude proximal flailing, choreiform movements of limbs. Lesions of contralateral subthalamic or other parts of basal ganglia, usually stroke. Athetosis, slow convoluted writhing movements of fingers and toes. Pseudothetosis similar but elicited by eye closure. Early life damage to basal ganglia, hypoxic, kernicterus, vascular, pseudothetosis caused by proprioceptive pathway lesions. Tic. Stereotyped, brief, purposeless, rapid movements that break the flow of normal movements, common premonitory urges, can be simple or complex, motor or vocal. Tourette syndrome, autism, developmental delay syndromes, Huntington disease. Myoclonus. Rapid, shock-like, jerky movements of isolated body parts. Metabolic, uremia, hepatic failure, electrolyte imbalance, serotonin syndrome, post-anoxic, Creutzfeldt-Jakob disease, corticobasal degeneration, sleep-related, hypnic jerks, nocturnal myoclonus, myoclonic epilepsies. Akathisia, inner restlessness associated with repetitive movements. Drug-induced, restless leg syndrome. Psychogenic. Highly variable, inconsistent, distractible, acute onset, episodic, tremor frequency suggestive of different frequencies, most fixed dystonias. Conversion disorder, malingering, factitious illness, somatoform disorder. Parkinson disease. Most common hypokinetic movement disorder. Slowly progressive neurodegenerative disorder associated with gradual loss of dopamine-producing neurons in the substantia nigra. Environmental, pesticides, herbicides, well water and excessive manganese, and hereditary, ADLRRK2, AR-Park2, risk factors are implicated. 4 cardinal signs of Parkinson disease. Resting tremor. Unilateral at onset and remains asymmetric. Bradykinesia. Core feature. Slowness and gradual decreasing of the amplitude of repetitive movements, reduced facial expression, reduced arm swing, small hand writing. Rigidity. Associated with a cogwheeling quality in the presence of tremor. Gait/postural impairment. May start with shuffling, dragging of one leg, and mild disturbance of postural reflexes at turns, to hesitation at onset. Of gait and turns, freezing of gait, and severe loss of postural reflexes. Other non-motor symptoms include autonomic dysfunction, hyposmia, constipation, REM sleep disorder, and problems with sleep, mood and cognition, slow processing speed, impaired short-term memory, attention, deficits with relative sparing of cortical functions. Diagnosis is clinical. Presence of bradykinesia with at least one other cardinal feature, resting tremor, rigidity or postural instability, and the absence of Red flags for atypical forms of Parkinsonism. MRI is done to rule out vascular lesions and hydrocephalus. Currently no medication can slow down the progression of the disease. Strong recommendations for physical activity and physical therapy. In patients with mild symptoms, monotherapy with monoamine oxidase. Type B inhibitors can be considered as initial therapy, modest benefit. Are dopaminergic medications, including levodopa and dopamine agonists, are the most effective. Levodopa is usually combined with carbidopa. Used dopamine agonists in younger patients, and LT65-YO, to delay levodopa. Related complications. Dopamine agonists are associated with higher risk of specific adverse edema effects, including impulse control disorder, punding, sleep attacks, ankle edema, hallucinations, and confusion, that may limit their use, especially in older patients. Levodopa should be started as initial therapy in older patients and as replacement or additional therapy in younger patients who did not benefit or had adverse effects from dopamine agonists. As Parkinson disease progresses, the medication regimen should be adjusted to address progressive motor deficits and minimize evolving medication-related complications. More frequent use of immediate-release levodopa. Using sustained-release levodopa. Adding a dopamine agonist, a catechol-methyltransferase, or monoamine oxidase type B inhibitor. Adding mantidine in patients with dyskinesia. Adding anticholinergics in patients with prominent tremor. Using clozapine or quizapine for medication-induced psychosis. Monitor for infections, metabolic derangements, and discontinue anticholinergics, amantadine, and dopamine agonists. Deep brain stimulation may be used in patients who have a sustained motor benefit from levodopa but are limited by drug adverse effects. They are unresponsive to medical management. Parkinson plus syndromes. Suggested by the presence of defining features, a faster progression, and the absence of levodopa responsiveness. Primary syndromes are progressive supranuclear palsy, Parkinsonism with oculomotor abnormalities, including impairment of vertical SACC-AIDS and supranuclear vertical gaze palsy. May also manifest with facial dystonia, axial rigidity, and prominent postural instability with early falls. Multiple system atrophy. Comprises three subtypes that are characterized by a combination of Parkinsonism and prominent dysautonomia, Shy-Drager syndrome, cerebellar ataxia, MSAC, or dystonia, MSA with predominant Parkinsonism formerly known as striatonigral degeneration, or MSAP. Corticobasal degeneration. Present with markedly asymmetric Parkinsonism and often is associated with dystonia, myoclonus, cortical sensory deficits, and cognitive deficits, including impairment in motor planning, apraxia, calculation, and left-right distinction. Brain MRI may show asymmetric cortical, particularly parietal, atrophy. Drug-induced Parkinsonism. Suspect in patients taking dopamine receptor blocking antipsychotic agents, haloperidol, chlorpromazine, risperidone, olanzapine, ziprasidone, aripiprazole, antiemetics, metoclopramide, ziprasidone, dopamine depletes, tetrabenazine, reserpine, mood stabilizers, and antiepileptics, lithium, valproic acid, amiodarone, flunarizine, and SSRIs. Oftentimes reversible but may resolve for as long as 6 months after drug cessation. Drug-induced Parkinsonism may be distinguished from idiopathic Parkinson disease on the basis of the symmetry of symptoms and the absence of typical non-motor features. Essential tremor. Characterized by rhythmic and oscillatory movement and classified on the basis of its association with rest or action. Typically presents with a bilateral upper extremity postural and action tremor. Common features include a reduction of tremor amplitude with alcohol, an age of onset in late adolescence or middle age, a slow progression, and the possible development of neck and vocal tremors. Familial in 50%. Differentiate from enhanced physiologic tremor, normal low amplitude, high frequency tremor seen in association with triggers, such as stress, drugs, and thyroid disease, similar to essential tremor but resolves with resolution of underlying physiologic stressor. Treatment is symptomatic and for more disabling tremors only, propranolol, primidone, clonazepam, topiramate, gabapentin, nimodipine, botulinum toxin injection, thalamic DBS. Dystonia involves sustained, stereotyped, and directional twisting and posturing movements of various body parts. May be generalized, most common is associated with DYT1 gene mutation, or focal/segmental, cervical dystonia, eyelid dystonia, vocal cord spasmodic dysphonia, task-specific hand dystonia. Onset is end LT 25 years old. Transient improvement of dystonic movement by a sensory trick, gest antagonist, such as specific sensory stimuli, gently touching the involved area with the hand, provides further diagnostic clues. Causes may be metabolic, genetic, ischemic, and infectious. All patients with primary generalized dystonia should be challenged by a short trial with low-dose levodopa to screen for dopa-responsive dystonia, a rare but treatable cause of generalized dystonia. Screen for Wilson's disease in young adults. Limited benefit from medications but often include anticholinergic agents, benzodiazepines, baclofen, botulinum toxin injection, focal dystonia, and DBS, generalized dystonia especially if positive for DYT1 mutation. Choreiform disorders. Chorea consists of random, non-repetitive, flowing dance-like movements. May be caused by medications, such as antipsychotic agents and estrogen-containing drugs, endocrine derangement, as in thyrotoxicosis and acute hyperglycemia, pregnancy, chorea, gravidarum, streptococcal infection, sydenham chorea, autoimmune disease, systemic lupus erythematosus and antiphospholipid syndrome, and neurodegenerative disorders involving the basal ganglia. Huntington disease is the most common neurodegenerative cause of generalized chorea and is associated with progressive Parkinsonism, gait impairment, impulsiveness, psychiatric disorders, and dementia. Confirmed by genetic testing. AD transmission. Symptomatic treatment. Tic disorders and Tourette syndrome. Tics are stereotyped, brief, rapid movements that break the flow of normal movements. May be partially suppressible. May be generated to achieve transient relief from preceding uncomfortable focal sensations, premonitory urges. Most starts early but would have full remission in adulthood. Tourette syndrome is characterized by childhood onset, persistence of multiple complex motor tics for at least 1 year, and presence of vocal tics. Examples include echolalia and coprolalia. Causality remains unclear, may be due to a disruption of the basal ganglia frontal cortex network. Common comorbidities include ADHD, OCD, and mood disorders. Management includes reassurance, cognitive behavior therapy, and treatment of psychiatric comorbidities. Medications include antipsychotic agents, pimozide, haloperidol, aripiprazole, ziprasidone, risperidone, alpha-2 adrenergic agents, clonidine, guanfacine, benzodiazepines, dopamine-depleting agents, tetrabenazine, topiramate, and botulinum toxin. Restless leg syndrome. Characterized by discomforting sensations in the legs at rest or when falling asleep, an urge to move the legs, and immediate relief after moving the legs or walking. Screen for IDA. SSRIs and dopamine antagonists aggravate RLS. Medications with strongest evidence for its management are the dopamine agonists, pramipexole and rotigadine patch, and gabapentin and carbol. Other pharmacologic options include ropinirole, levodopa, opioid agonists.